Welcome everyone to another episode of Three Plastic Surgeons and a fourth, not and a mic and a microphone, even though there's only three plastic surgeons today. As always, I am Sam Jejurikar in Dallas, Texas, and I'm joined by Dr. Lawrence Tong in Toronto, Ontario, who is at Yorkville Plastic Surgery, and Dr. Sam Rhee from Bergen County, New Jersey, who is at Bergen Cosmetic. And today we're going to talk about an interesting topic that was actually prompted by a conversation we had a few podcasts ago, and that is how we size patients for breast implants. At the previous podcast, Dr. Rhee had made a quip about patients with large implants. I think you said 650 and implied somehow that they might have low self-esteem or might have, and he'll get to actually present his version of the thing, but of what actually happened, but suggest that maybe they had motivating factors that weren't the best. And we didn't really get into how we actually help our patients pick implants. So that's going to be the focus of what we talk about today. Before we get into the meat of the issue, Dr. Tong, you want to lead us with the disclaimer?
Absolutely. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment of the appropriate discussion. Always seek the advice of your surgeon or other qualified health professional with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in this show.
Perfect. So, I guess just to lead off, a lot of times when I will see patients coming in for a breast augmentation consult, they'll have pictures from social media where they will show pictures of other patients and they'll say, I really like this result. I want a 450cc moderate profile plus implant. What they don't know is the height of that other patient, the weight of that other patient, and how that patient might actually compare to that. And so we have to take a step back in terms of how plastic surgeons think about sizing patients for implants versus how patients might do it. So Dr. Tong, imagine you're seeing a new patient in your office who wants to talk about a breast augmentation. She's there in your office. She's a blank slate. She wants to know what you think. How do you approach how you're going to help this patient select the right size of breast implant?
So the way I sort of think about this at a zoomed out view is that primarily you want to get a result that the patient wants. So you need to know what kind of look the patient wants. And obviously the consultation is for them to tell you that. And they might show you pictures from, whatever source. But then I think the job of the plastic surgeon is to guide that patient along so that they can choose an implant that meets their needs as much as possible. And the caveat to that is there are going to be certain factors that the plastic surgeon will be assessing to try to get the sort of best result for them. Things like their anatomy, things like, if they have, specifically, if they have already fairly large breasts or small breasts, or what are their measurements, if they have asymmetries and things like that. So I think it's my job to sort of try to guide them as they choose their implant. I'm never the kind of surgeon, and I'm sure you guys aren't either, to just look at somebody and say, okay, you have to have this sort of implant. My job is sort of to guide them to try to choose the best implant that works for them and also fulfills their sort of wants, or at least as close as possible.
So let me provide my version of the story that that Sam is talking about in terms of how we got to talking about sizing of implants. Larry, you're absolutely right. It is our job to guide patients. There are a lot of factors that you mentioned that all play a role. But the reason why we brought this up, and we discussed it before, it was a couple episodes ago. We were talking about difficult patients, and I had a patient who came in, and she says, I want 650cc implants because my sister has 650cc implants, and that's exactly what I want. And I said, well, I think it behooves us to find out a little bit, like, what is the motivation of this patient? Are you, what's your relationship? Like, why are you mentioning your sister when you're talking about your body? And the quip that, and obviously it was a joke that Sam said was, well, what I would say is, we go up to 800. Why not go bigger? Because everything's bigger in Texas. So that's what, so that would be the response that someone like Dallas plastic surgeon, Dr. Jejurikar would say. And then he's obviously kidding. But I would say when you size a patient, there are many motivating factors, as you mentioned, in that patients bring to the table. And one of them is, I want to look like someone, whether it's in social media, someone they know, someone who has already had breast augmentation, and that's pretty common as well. And so what Larry said is, we have to help navigate it. You might have a look, but that implant might not give you that look. So what is it that we have to do? What factors? How do we guide you to get to that look that you want, even if you don't look like that person did before they had their plastic surgery done? So how do you do that, Dr. Jejurikar, in Texas?
As it turns out, everything is not bigger in Texas. So I think what you guys have been saying is that we need to have a dimensional analysis to the patient. When we're thinking about how we're going to get an implant that's going to fit our patient, we're thinking about anatomic measurements, specifically what's the width of their chest wall, what's the width of the breast on the chest wall, and what's the degree of breast ptosis, which for the listeners out there is the degree of droopiness that they have. And all of those factor into our decision-making process. Fact of the matter is, if you pick an implant that's too wide for a patient's chest wall, it's not going to look good, and it's probably going to lead to some postoperative complications. Within that, within those measurements of implants that'll quote unquote fit in the chest wall, though, plastic surgeons are able to vary what's called the implant profile. The implant profile is basically an adjective that describes the relative width of the implant and how much it sticks out for that width. So the more the adjective sounds like the word high or extra high, the more the implant sticks out relative to a given width. And the more it sounds like low or moderate, the less it sticks out. And in general, and there's a lot of exceptions to this, but in general, more natural looks are more affiliated with a profile that is going to sound more like the word low or moderate. Conversely, a faker look, or one that sticks out and gives you a slope on the upper aspect of the breast, is one that is going to give you a faker look, and that's more of a higher profile look. So my approach is dimensional analysis, do measurements, figure out, like you guys were talking about, what's the look the patient is going for, and then figure out what is actually possible. So, gentlemen, let's say we do this dimensional analysis and you have a patient with a really wide chest wall. Let's say they have a base width of their breast of 14 centimeters or 15 centimeters. And they say, no, I want a really small implant. I want an implant that's only going to be about, 150 cc's. I barely want you to be able to see it. How do you handle that situation?
So, in some cases, this may or may not be one of those cases, but in some cases, what a patient wants, they can't necessarily get. So, if a patient says, this is a classic, I want to, I want this large size implant, but I don't want it to feel that heavy, or, they'll say things sometimes that contradict each other. And then sometimes I'll have to tell them, well, you can have one or you can have the other, you can have a compromise between the two, and you can't always get it. But it's the example that you mentioned. So for the listeners, in general, we like to choose an implant that is going to fit the breast width. So if the example is 15 centimeters, you sort of want to ideally try to choose an implant that's about 15 centimeters wide. And for the listeners, in general, as the width of the implant increases, the size of the implant also increases. So the volume of the implant increases. And so if you're choosing a 15 centimeter implant, you're usually obligatorily having a larger implant. So the way that I would deal with this, if she doesn't want larger implant. First, I would say, well, you're going to have to go a certain size. But then the other thing I would do is, as Dr. Jejurikar had mentioned, is probably go with a lower profile. So that means that the implant doesn't stick out that much and it won't have as much volume. And so that can achieve, a smaller cup size. My goals when I size patients is to try to get an implant width that fits their chest. And then based on that, we'll start trying some implants. And when I say trying some implants, the typical thing I'll do is have a patient put on a bra that we have, sort of a tighter fitting sort of sports bra. And we'll have all the implants there in the office and they can, try any of these implants on. And I'll start by, picking a size that's sort of in the mid range of what I think, or very close to what I think they'll want, and have them look in the mirror after they have them on. And then they can give me some feedback. If they want to go bigger or smaller, then we'll just keep going bigger or smaller until they get to the point where they have it narrowed down to a size that they want. Usually it just takes a few, tries, and patients generally get a pretty good idea of what they want.
Do you find that that's accurate, that using a sizing bra and using implants correlates pretty well with how they're going to look post-operatively?
So the other thing that I have is the imaging, which is it's a system where for the viewers they go in front of a camera system that takes a picture of the chest, and then computer software generates a 3-dimensional model from that, and then from that software you can actually try on implants, and they can see what it generally will look like. The one that I use is Vectra. There are other competing systems. I find that actually Vectra is less accurate than trying the implants on with the bra. So I'll use the trying on the implants as my primary method. And then sometimes if patients want to see what that looks like to the Vectra, I'll do that. But I find that visually, or for whatever reason, the image on Vectra looks smaller than what they'll get. And I learned this a while ago when I first started using this system, where I would have patients only choose their implants using the Vectra imaging. And what I found was that they consistently chose an implant that was way too large.
Interesting.
Yeah. So I don't have any experience with the other systems, but that's what I found to be the issue. And I found that with the, dimensional analysis and trying on implants with a bra, that's generally the most accurate way to get a happy patient. Yes, the bra method is not entirely accurate. I usually tell patients that they can expect a slightly smaller size when the operation is finally done. So I would say maybe anywhere from about 10 to 15% smaller than what they're seeing in the office with the bra method.
You okay, Dr. Rhee? You're channeling season 1 Breaking Bad Walter White over there.
Yeah. Look, just a little congestion there. I'm feeling okay, but I would say this. So you're right. I think the two ways most surgeons will help patients is either with some sort of imaging software or with some sort of sizing, physical sizer type method with dimensional analysis. And I think both ways can be really helpful for patients. I think it is very dependent on the surgeon. Just like we always say, in my hands, blah, as a surgeon. Like same thing with how we help patients get to implants. I don't think there's one right way. I think whatever way that surgeon chooses, that is the way that works for them. Just like we have different instruments, techniques that we all use that vary in some way. I think for me, I am a sizer guy for a couple of reasons. One is I like that patients can sort of feel what that weight is when they put it in them. Like when you see a picture, it looks awesome, but lady, you got to live with that, and you got to walk around with that, and you got to exercise with it. You got to move with it. And you may or may not necessarily understand that but when you use a sizer and you put that in, there is a palpable sense of that. I think the other thing is that for me, sizers tend to go a little small. Like, so Larry, you think you have the OR, if you use the same size, you would go 10 to 15%. It ends up being 10 to 15% smaller. I think I think the same. I actually have to go up a little bit with the implant to reach the desired sizer that they want. So, for whatever reason, I have experimented with imaging. I think imaging is great, and I know Sam, you use it, so I'd like to hear your take on that. It really is what you make of it as a surgeon helping your patient. I think it's not likely that I will see a patient who's 15 centimeters wide who wants a 150 cc implant. It's usually someone who's like really tiny and petite who wants a really large implant. And that's where we're sitting there saying, listen, this may or may not be even technically feasible. And even if it is, you may not like that look. And so it really is, as Larry said, working with different volumes, different sizes to help a patient, because I have had some very, very small, petite patients who wanted very large implants at first. And I said, listen, my job is to help you achieve what can be technically or realistically achievable. And this is not the case in this instance. But most patients fall somewhere in the middle where they can physically accommodate the implant. It's really about aesthetically achieving that result that they want.
I am seeing with equal frequency the patients with wide chest walls who want small implants that are hard to actually sit within there, as much as I am seeing the petite patients who want to be really big. It only used to be that second one that I would see, but now I actually tend to see them with relatively equal frequency. In terms of using sizers, I still occasionally use them. We used to use them exclusively in our practice. I also found that if they liked the way that the sizer looked, if I was going behind the muscle with my implant, I'd have to go up 25 to 50 cc's to accomplish that look. I think there's something about the implant sitting in front of the breast that makes it look more projected in a sizing bra. That probably contributes to the look that the patient wants. So when you're going behind the pec muscle, or even just behind the breast gland, you need to accommodate for that. I've used Chrysalix, which is sort of the other major competing 3D imaging to Vectra that Larry was talking about. I've never used Vectra. I've used Chrysalix a lot over the last 8 years, and it's changed a lot over the last 8 years. I didn't think it was very good when it first came out, in all truthfulness. Around the pandemic, they really started changing the software and started incorporating more AI and machine learning to it, and that the models they were creating were better. And they just keep getting better as that sort of AI machine learning component is changing. And they've actually just updated it in the last couple of months so that it's gotten even more accurate. I do find that it is pretty accurate and that the looks that I accomplish from a sizing standpoint match up pretty closely. And I also like it because if I'm doing an initial consultation virtually with a patient, which is a lot of the patients that I see, that kind of became a big thing during the pandemic and it's sort of stuck with us. I can do that with Chrysalix and actually do a really good job of sizing people. And then I'll see the patient the day before their surgery just to confirm it with measurements. But I do agree with you that having that palpable sense of what the weight of the implant does is important for many patients. And I think particularly if they're going with an implant that's really large, it's important for them to get a sense as to how heavy that might actually be. I want to ask you guys about another very common scenario that we see, and that is, how does your choice of breast implants vary if you see a patient that has a lot of breastosis and you think they need a simultaneous breast lift? Meaning, do you still use the same metrics to pick the implant, or might you be more conservative in your choice of implant if you're going to do additional procedures on the patient to tighten their breast gland at the same time?
So, for the viewers, when a patient has droopy breasts, you can't necessarily just put an implant in because the implant will sit at a certain point in the chest. And if the breast is fairly droopy, it's going to sit way below that implant, and it's going to give you a very strange look. So in those cases, we will discuss having a breast lift. Now, breast lift is a procedure that involves reshaping the soft tissue, moving the nipple and the areola upwards, and it involves removing some skin when we do that surgery. So in those situations, you have to be wary of that, because when you put an implant in, you're going to make the skin envelope tighter because you're expanding the volume. At the same time, if you're doing a lift, you're going to be removing skin. So you have to be very careful that you're not getting into a situation where you are putting in an implant that's so large, and then you're trying to do a breast lift at the same time that makes it so that all the incisions are very, very tight. And that's detrimental because in the worst case scenario, you can have the wound open up. That's unlikely. But in a more common scenario, the scars are going to look worse. Whenever there's a lot of tension on the scars, when the scars are tight, the body is going to sense that the wound needs to be stronger, and it's going to respond to that by putting down more scar tissue. That's what you don't want. You don't want to have a bad looking scar when you do these surgeries. So to answer Sam's question, I won't be as liberal in terms of the overall implant size when somebody is going for a breast lift at the same time. That might just be limiting the actual volume, or maybe in some cases, sticking to a moderate profile as opposed to a high profile implant. I find that I've been surprised when sometimes I've thought that in a patient where they might have chosen an implant that I thought was going to be a certain size after the lift, it actually looks a lot bigger once the lift is done for whatever reason. So I think that my general approach is choosing an implant that's probably a little bit smaller than what I would usually use if I was doing a primary breast augmentation with no lift.
I think there are a couple moving targets here when you're working with a patient who has a certain amount of ptosis or droopiness. So the first is determining how much droopiness there really is, and how much is the patient willing to accept. Because as you know, when you do a lift or a mastopexy, you're putting scars on the breast, and that's a hard stop for a lot of patients, and I understand that. If that's the case, you as a surgeon have to help the patient understand how much droopiness, or as Larry says, ptosis, they're going to end up if you just put a straight implant in. And there are different ways we sort of manipulate it, like techniques and stuff, to try to help with that. But that's something that you have to sort of work with the patient and understand. And I have, in many patients, gotten, they're willing to accept a certain amount of droopiness. They even think it's a little natural appearing, put in a reasonable implant, and they were really happy with that. In other cases, I just know, listen, this droopiness is way too much. There's no way you're going to be happy, I think, from what I can tell talking to you, that you would accept that without these incisions. And in that case, I've gotten, I think mastopexy aug, or what we're talking about with putting implants in with a breast lift, is very surgeon it's experience dependent. I've gotten way more comfortable over the past 5 or 6 years doing it than I ever was. I mean, this was something back in the day when we trained that was like a third rail, be careful, sort of situation. And I think with experience, I've gotten comfortable with fairly large implants with a lift. Now, the issue really is you can achieve a pretty good result, like even a great result that way. But you got to remember that droopiness is progressive and it will continue. And so I talk to patients, you choose a really large implant, we can do a great lift, but that doesn't mean that weight isn't going to keep pulling that breast down. And so there are ways to mitigate it. I know, Sam, you might talk about that, or what you might use, or different techniques. I know, Larry, you might talk about that too. But it's really a complex interplay of, like, what do you feel comfortable as a surgeon putting in? What is the patient willing to have in terms of scars? And will the final result turn out the way that particular patient wants? And I think experience counts for a lot. There's a lot of intuitive thinking when I talk to a patient about it, like, as Larry said, can I make sure the scars stay nice and tight? Can I make sure I get the nice lift? And a lot of patients, when you put an implant, if they're droopy to begin with, just getting the lift alone makes them feel like they're bigger to a certain degree, because it's always been that volume's been so down on their chest, sitting on their, halfway down to their belly. Once you just put that volume up, they feel like they've gotten an aug almost. So you have to sort of play that into consideration. So as you said, Larry, it might be a smaller implant, but they might think it was actually a bigger implant just because of the reshaping that you did with it.
I think those are great points that you both made. Um, I am very much sort of the Larry school of thought, where in general, if they're doing a lift, if they need a lift and they want a simultaneous implant, I do tend to heavily try to steer my patients towards smaller volumes and more moderate profile implants. Again, this is why I like 3D imaging, because I can I feel pretty good that the images I'm showing them with that are pretty accurate of what, and if it's clear that when they see that that's not going to be enough volume for what they want, in that scenario, I either will try to convince them to be happier with a smaller volume, or I'll try to actually talk them into staging it, where they would do the lift in stage 1, maybe do some fat grafting at the same time to give them a little more upper pole fullness. But ultimately, come back 6 months later, do a relatively straightforward breast augmentation to give them the size that they actually want. Because although it's not a hard and fast, I won't put in a big implant, my complication rate's pretty high when I put in a big, high profile implant at the same time as doing a lift. It can be recurrent droopiness, it can be poor scars, it could be widened areolas, it could be all of the above. But it's, it's not insignificant. So, patients will tell you at the time of a consultation that they're going to be okay if they need a revision, but they're really not okay with it if they need it when the time actually comes. But I do think, I think the trend that we all have here and that we're all saying is, if you're needing a breast lift, there may be a situation, if it's a mild degree of ptosis, where an implant alone might make you happy, and it's important to communicate that with your patient. But if you need a breast lift, nobody wants a breast lift, but if you need one, you need one, and you're going to have to get it. And then the timing of the implant will very much depend on, how much volume you actually want.
What size do you guys consider big? Because I rarely honestly put in anything more than about a 550 in my practice. Like 600 plus is pretty unusual.
In a general sense, yeah, I would say 500 is my sort of definition for a big implant. Of course, it depends on the patient's height and chest width and their overall body habitus, but in general, 500 is the cutoff point for me, because I think that despite the body habitus, the weight is the same no matter where you put it on. And that's the cutoff where you start seeing the complications, the malposition, the stretching of the skin, the unpredictable way that implants settle. So I think around 500 is when I start telling patients, okay, you can get this implant, but there are higher risks that could potentially happen. It's not necessarily going to happen for sure, but the rate starts jumping up at that point.
Are you referring to big with a primary aug or with an aug pexy?
I'm referring to primary aug.
Okay.
So I would very rarely put in a 500cc implant in an aug aspect. Of course, again, depends on the patient's body habitus and height, but
right.
I can't think of the last time I did that.
Yeah. I think, not to make too nuanced of an answer to your question, Sam, but I had two sisters recently who were both like 6'1" that I operated on. And for them, I think I used 450, 400cc implants. And that was a very conservative, moderate profile implant that didn't look like that big of an augmentation. But in your typical, 5'1", 5'2", 5'3" patient, I would consider that to be reasonably large. I think I consider, with that disclaimer, I think I would consider anything bigger than about 450 to be a big implant. That doesn't mean I don't put in big implants for primary augs. I do it. I mean, I do it with some frequency. But it tends to be more of a high profile implant in a patient to try to fit that dimensional parameters that we were talking about before.
Got it.
Okay. As a interesting thing that I've seen, and I'm just wondering if you guys have seen the same thing. How many times have you seen it when a patient comes in with something from Instagram or whatever? They show you a photo on their phone. This is what I want to look like. And then you measure them out and you say, okay, you can, it'll work for you. And then you have them try the implant, which you think will achieve that, and then put on, they go, wow, this is way too big. Do you guys get that reaction? Because I get that
sometimes,
fairly often, I think.
Yeah.
And I think that's just a reflection that what you see on the internet might look good to you, but when it's on yourself, it might not be that appealing.
It's like an old wives' tale where patients always used to come in and all their friends would always would tell them, well, go, when you see the implant you like, just go a little bit bigger so you don't have regret over that. That's just not the way it is anymore. More commonly, there's concern that they're going to end up too big. And so I think what you're describing is very common, Larry. And then conversely, it seems to be just as common that patients think it's not big enough when you pick the implant that you think is going to work for them. So
I don't see as many of those as I see of patients who are indecisive and they are vacillating over one size versus another, and they can't make up their mind, and they talk to their friends and then they come back. And so those are the patients that I often counsel, listen, don't listen to anyone else. Go with your gut. Whatever your real intuition is telling you, that's what you should stick with. And more times than not, if they really go with what they feel true to themselves as opposed to listening to others, they are more than happy. And sometimes it takes a little bit of resisting peer pressure when everyone's telling you, go, like you said, go a little bigger, you're going to regret it, blah, blah, blah. And they say, you know what, I think this is really what I want. More often than not, they're really happy with when they stick to their guns and they choose what they choose.
Yeah, I agree. Well, as we wrap this episode up, gentlemen, what are sort of the key points you think our listeners need to take away from what we've talked about today?
So I think that it's important for your surgeon to take into account your anatomy and for your surgeon to take into account what you want to achieve, and have your surgeon sort of guide you through the process of choosing the one that hopefully will achieve both of those things optimally, but also understanding that sometimes you have to make some degree of compromise on one or the other.
I think there are a lot of patients who have told me of surgeons who tell them this is what you must have, or, sort of take the decision-making process out of their hands. That is not what we're talking about here. If you listen to Larry and Sam, we're helping you try to achieve what you want, but you have to know what you want, and you have to know that that's what our goal is. We're not trying to make you look a certain way. You tell us what you want, and we'll tell you if that's technically possible or what it would take to achieve that. And we have a lot of different ways of doing that, as you mentioned. So, the best thing to do is pick a surgeon that you trust, stick with that trust, but also believe in what you believe in terms of what you want. And 9 times out of 10, we'll help you get there.
Yeah. Well said. And I don't think I have much to add to that, but to our listeners, if Dr. Rhee does happen to be your surgeon, just remember that if your implant is 650 or greater, or I guess 500 or greater, he may be wondering what your motivation is. And with that, thanks everyone for listening, and we'll wrap up this episode yet again.